But we have a fascinating program here, absolutely cutting edge, and Stephanie and I are really excited to open the session. And our first speaker is going to be Wenyin from Jefferson Hospital for Neuroscience in Philadelphia, automatic brain metastasis tumor segmentation. Wenyin?
Thank you very much. Thank you very much for the opportunity to speak here. And we are a long-term user and a collaborator with BrainLab. Our first Novartis system actually is one of the first in US in the 1990s. And today I was given the opportunity to talk about a new development with BrainLab, which is automatic brain metastasis contouring. So here's my disclosure. I do want to mention that this development product is still in development phase, so it's not released, FDA approved. And I just want to give you a sneak peek of what its capability and give us a very early kind of our own experience of testing the software. And I will thank you, the BrainLab organizer, and about them put this AI session together. I think we all know that AI is changing our life, and it really penetrate into everything, our everyday life, as well as healthcare. But for radiation oncology, we are a very technology-driven field. As you can see, AI is really reached every single step out of how patient cares through the process of going through radiation treatment, particularly in a high-end treatment like radiosurgery, SBRT treatment. But I want to, also mention that ultimately we will not just want to simply look at workflow optimization, reduce the burden of the repeated task, but ultimately we want to prove all those innovations are lead to the improved patient outcome. And this is one of the goals, and we think we will achieve with all those new technology innovation. We already have a lot of topic on this, and everyone is very familiar with the field. I don't want to spend too much time on it. And some of the prestigious speakers early today already talked about this. But I think we just want to get a better understanding of the background, so truly understand what's the role or why we are actually focusing to develop auto contouring, try to introduce this into our current workflow. And so, as you know, the brain metastasis is a high incidence disease, and the incidence will continue to increase with the factors our speaker already talked about earlier today. And there's certainly some of the important things we need to memorize. And one is clearly there's increased use of radiosurgery. I don't need to preach to the prior, and I know everyone here is active practice user of radiosurgery, and we are certainly believe the radiosurgery will be better suited for many of the patients with brain metastasis. And, but the complexity of brain metastasis radiosurgery really is changing very rapidly. So the solution working very well 10 years ago may not suit our need now or in the near future. And as you know, we have broadened our indication for radiosurgery for brain metastasis. We're really practicing for multiple brain metastasis. We don't really have a number limitation, not a magic 10 or 5, 15. It's really actually looking at the patient as a whole, as well as the tumor burden intracranially. And certainly the mass-based radiosurgery solution provided us to treat much larger lesions than previously were not considered suitable for radiosurgery, such as large brain resection cavity. And we also have pre-op radiosurgery become much more preferred and under very active prospective investigation. And that's also require very fast turnaround of workflow. And such other disease previously not considered suitable for radiosurgery also become a part of the routine candidates. So not only patients become much complicated to begin with, but they also have multi-course longitudinal management. So all these require us to really have a very good solution for us to, one is achieve a high efficiency to take care of those patients. We're able to, from patient for simulation to treatment quickly, but also we want to make sure we have high quality, make sure all the treatments are delivered in the very consistent, high-quality way. So certainly we need some very well-developed radiosurgery solution. One of the solutions certainly many of us use here is the BrainLab multi-element radiosurgery solution. And if you look at the workflow, it does address many of our important tasks in the workforce, including imaging fusion, including OER auto-segmentation, and there's assisted target delineation with smart brush, but the planning process is very automatic, and delivery is efficient because model isocentered. I want to think, the target delineation clearly is one of the potential target that we can look into further improve because there are still, challenges in the target delineation. And I started to talk with mention about AI in radiation oncology, and just looking at AI paper published in the past couple of years, and the review paper looking at all the things and topics looking at the AI. And interestingly enough, almost half of the AI topics is looking at segmentation. Obviously, many of them looking at a normal tissue or OAR segmentation, but clearly there's a lot of effort looking at target delineation, including the brain as one of the topics. So why we think about we still want to improve our contouring, particularly using AI to assist. One is obviously when we talk contouring multiple brain metastases, it can potentially be time-consuming. And not only the contouring itself, but also carefully evaluating the brain MRI scan, make sure you don't miss small lesions, and itself can be a task for an experienced user. The accuracy or the quality can be good for a new user, and the quality of contour or potential missed lesion risk can be higher. And there's a study looking at the contour consistency, and the study published a little bit a while ago. They're looking at the contour variability of different users. As you can see, there's a very large variability of the contouring for brain metastasis. So even brain metastasis generally we consider a very straightforward contour, but it's actually not that consistent, and we need to pay a lot of attention to that. Even a more recent study from UK looking at a similar study looking at different contour experience with different users, they're still seeing that brain metastasis has a very higher intra-observer contour difference, particularly for smaller brain metastasis. So this is the new feature of the Brain Lab, try to address all the issues and not only help us to improve efficiency, but also I think in a way can potentially in the long run to help the quality. So the cranial tumor segmentation, and we are able to have started our initial evaluation, but we don't have too much data to share, just mainly showing some our initial experience using the software. And the method of this is using neural network, deep learning, and GPU power segmentation methods. And it's capable of automatic contour multiple lesions at the same time. And it certainly is designed to help radiosurgery and potentially assist surgery as well. So this is one of the cases we first test in our experience. First of all, we want to see how efficient the contouring is. So this is automatic process. Once you load the MRI scan into the system, it automatically generates the contour for you. And this is one of the extreme cases we treated. So there's more than 30 lesions, and the contouring actually takes less than a minute. So most of the contour, just like we see auto segmentation for the OAR, is actually very fast. A similar time frame, we're actually seeing the contour be generated. And as you can see, the workflow is pretty similar than OAR contouring. So it does require a user verification and allow the user to modify the contour while you review the target generated by the system. And we also see that the software can detect very, very tiny lesions. And the lesion as small as 0.01 cc can be detected. And so this is one of the cases, and I'm going to show you more example of other lesions with 9 lesions clinical treated, and the software actually was able to detect 10 lesions. And this is the lesion that the software picked up, and we have to turn off the contour and change the contrast, and upon review, it does consistent with a lesion. But obviously, this is retrospective. We do not know at the time the clinical decision whether it's the elect not to treat or is actually was not picked up by the radiation oncology treating the patient back then. But nonetheless, it's very clear the software is able to be efficiently, automatically detect multiple lesions, and this is all done with our regular diagnostic MRI scan. We have not made any changes with our scanning process. It's using our existing MRI scans that can all work, and they can detect very, very small lesions, potentially lesions that can be missed by clinicians. Regarding the contour accuracy, and this is one of the examples. It's actually pretty straightforward contour, a very spherical lesion, but if you zoom in to see that, we do have the clinical contour and the AI contour overlay, and the green is the AI contour, but you can see there may be some areas not perfect, but a small adaptation may be needed. So it certainly requires user review and potential editing. More challenging, what we see is some of the lesion with the cavity. This was just not unexpected because the AI model was trained by existing cases, and they actually used the registry data. As you know, even though we do have the international the guideline regarding how to contour the cavity, the inter-observer agreement is actually not very high. And so that is not surprising. But on the other hand, you can see the AI certainly in certain area, which marked by the yellow arrow, it clearly missed small portion of the enhancing tumor, which is non-controversial at all. So I do want to spend the last couple of minutes talk about our plan and really think about what we need to do to really evaluate and integrate the automatic contour algorithm, because there are many other groups starting to develop this both for brain metastasis, primary brain tumor, or even extracranial disease. And evaluating matrix, as you can imagine, majority are geometry-based. And we're certainly thanks to our very talented physics colleagues. They have a lot of algorithm, to evaluate different parameters of the geometric coordinates of the clinical contour as well as the AI contour. And this is some of the example I highlight here. I'm not going into detail. But interesting enough, by the previous experience, we're looking at, for example, the dice similarity coefficient, all those parameters. Those has not been linked to clinical outcome difference, at least not consistent link. That may highlight one of the issue is what is truly is the ground truth, right? So currently, the ground truth for most studies are still rely on most experienced user contour. As you can see, if we go back to the clinical contour and we evaluate them, we may find that the clinical contour may not be perfect every single cases. So just using the clinical contour of existing cases, are they truly considered true ground truths? And those actually impact some of the matrix. So those are something we need to be very careful when we're doing those such analysis and reporting. Other things we need to pay attention to, including efficiency, which is so straightforward. And the dosimetric impact is actually one step take beyond the geometric impact, because we know the geometric matrix, but what kind of clinical impact it has. Actually, we can look at whether the geometric difference can lead to dosimetric impact. So that's one step further. And there's certain quality assurance. So they are basically using user to grade the quality of the contour with a scale, or you actually can do a tuning test, which is a blinded test. Basically, you blind the contour to a reviewer, and they pick which contour is better, but they're not knowing which one is generated by an experienced user and which one is generated by AI. But ultimately, I think we still need to take all those information together and to show that all those things have a clinical impact on patient outcome. Because, as mentioned, those dosimetry difference may or may not be sufficient to translate to a clinical impact, and we need to understand the implication of what we see here. But in summary, I will say, with our very initial experience looking at this new software, this is certainly a very welcomed feature, and clearly exciting to have that, I think, because this would help our workflow and definitely improve the consistency of the contour. One thing we can say, I will say, is the complementary collaboration of AI and the human is actually medical professional is needed, because at this point, we still need to verify the contour and add a contour. And so it's not just one way to be considered the actual ground truth. And often when we have the AI tool, we actually can have the opportunity to modify contour based on the further information provided. And so the software clearly will save the input efficiency and save the clinician time. And it will expect it to reduce the contour variability for different users. And for the clinician can certainly, I think our task will change from manually contour the lesion, more switch towards the quality control of the AI contour, or editing and verification of the AI contour. And hopefully it will enable us to spend more time for patient care. So ultimately, I think we need to show clinical impact. And so all the newer in technology, we need to see how they actually lead to clinical outcome difference, such as tumor control or a normal tissue toxicity. Maybe the registry will be one of the solutions to help us answer such questions. All right, thank you very much.
Thank you very much.